Hello, everyone. Good evening, and thank you for joining us tonight for the Ace the Clinical MRCPCH presentation. So I'm Katie, and this is Josh, and we are part of the London School of Paediatrics Trainees Committee, and so we are putting on this presentation this evening about the clinical MRCPCH and trying to cover some of the things that come up and some of the changes for the virtual exam. We are not experts in any of these things, and everything that we have learned from the RCPCH website. So do check on there and have a read through. There are lots of lovely documents, and there'll be some webinars coming up from the RCPCH in the near future. So the aim of the exam is to make sure that you are the standard of a newly appointed ST4, so stepping up onto the level 2 rota. It is aiming to go alongside the RCPCH progress curriculum, so covering all of the domains that we normally assess, so communication, history taking and management planning, rapport, physical examination, child development, clinical judgment, organisation of thoughts, recognition of the acute illnesses, your general knowledge of everything, professional behaviour and ethical practice. In terms of it now being a virtual exam, there will be some changes, but remember that generally the children have not changed. The things that they have wrong with them have not changed, so don't worry too much about it being a completely different thing. The stations that have changed most are the clinical station and the development station. The communication and history taking stations are pretty similar, and the video station is a video station. So this, and we will share all of these slides. This is the page from the RCPCH that has all of the, oh, can people not see the slides?
Not yet.
Yes, we can see.
Perfect.
Yeah, okay. So as I said, the differences are similar. This is the website page that you will spend the next few weeks looking at. So it's got lots of links already, and they are being updated as they are changing. In terms of the sort of general information about the exam, there's only going to be about 90 trainees in this sitting, so I know a few of you have already got in touch saying that you hadn't got on this time. And the plan is that this is sort of the pilot, and then plans to scale up for then future sittings, because obviously there are people who haven't managed to get in. There's still all of the normal reasonable adjustments in terms of any disabilities and things like that. You can sit the exam anywhere in theory. The documents actually say they advise against work, just because IT is likely to be even worse at work. The setting that they're going to be using is a system called Praktik-Oski, which they send out all of the technical details for, and you can practice before you start. They say specifically that there's no note-taking during the station, which is a bit of a change from the face-to-face exam in terms of, you know, for your clinical history-taking and your communication. Note-taking is helpful sometimes, but they say just because of the difficulties with a virtual exam for protection of the scenarios and to prevent cheating, that's what they said. There's going to be you, an examiner, and an invigilator, plus or minus a role player for every station. So there's an invigilator for every station to make sure that everyone is doing the right thing in the right place, taking the right time, so that you don't have to worry too much about that. Although you obviously haven't got your stethoscope and haven't got those things, you have to think about what equipment you would be using so that you can talk about it. And you're talking through all of your examinations and assessments, so that's the bit you need to practice. But always remember also the other things that you would automatically do when you're in these situations. So remember that you're washing your hands, you're checking for permission to do the examination, adapting to their needs. If there's technical difficulties, because unfortunately these things can happen. They have said that they're trying to arrange for either those stations to be sat at the end, or arrange for a full resit if required at a later date. Obviously we hope you won't need those, but they'll obviously take these things into account. This is a sort of draft version of the circuit. It's not confirmed, because they're piloting. They did one pilot of the exam a few weeks ago, and they're doing another one soon. And after that, they'll release the final circuit map. But basically, there'll be 2 communication stations, history taking station, video stations, short clinical stations, and an extended clinical station, which is new. And then the development is also adapted. This is their comparison of the 2 different stations, 2 different forms of the exam. So there's one fewer station. They're quite similar, but of note, there are role players in these stations, and there are no patients at all. So everything is either a discussion with a consultant or a role player. In terms of the timing, they've added an extra minute between stations for the technicalities and for the reading and introduction with your examiner. These are the timings of the different stations. So there's the extended clinical development and history are the long stations, and then the short stations, short clinical communication and video, of which there's 2 of each. And these are the markings per station. So I know some people like to be very canny in their revision in terms of going for the higher marks, and I mean there isn't really anything you can do in terms of that, but just to remember the things like communication and video, and actually they do count for quite a few marks, and sometimes you can forget them when you're going around and examining lots of children only. So like the previous exams, the marking is by clinical domains. So these are the domains: information gathering and sharing, physical examination, identification of clinical signs, clinical reasoning and management planning, and communication. They've said that they are reducing the amount of the rapport and communication style in terms of how important that is, because obviously, as you can probably tell, I'm not as good at communicating.
Identification of clinical signs.
And these are the anchor statements. So this information is all on the website. It just goes through the things. Obviously, you are aiming for meeting standard. There is no reason for you to be in borderline or below standard for any of these things. And again, for management planning, communication. And then these are the different stations and compared to the marking by clinical domains. So obviously, not all of the domains are accessible in all of the stations. And in terms of how the marking works, there's your marks are below standard, borderline or meet standard, and the maximum total marks for the whole assessment in the virtual form is 78, and they haven't confirmed what the pass mark will be. And then there's an additional domain of professional conduct, which doesn't count the overall mark, but then is considered. And then, unless it's very significant, which is unlikely, you are unlikely to fail based on that. So in terms of revision tips, the main thing to say is practice talking. So obviously, because you can't perform the examination, you're going to have to do the all of your talking pretty slickly. So make sure you can say how you examine everything beautifully. Stick with your small groups and practice. Be honest with yourself and your group. Make sure you're pushing each other. Don't just say, oh yeah, that was good, well done. Say no, say this. Make sure you get all of these people to test you. These people have all had to do the exam themselves. They've all had to make people test them, so they will teach you well. And make sure that you use people who you are scared of, because they're the people who will make you work hard and make you be ready for being scared in the exam. There's only a few weeks now to go, but don't go mad. Do give yourself some time to rest, otherwise you will overdo it and beyond it. There's the opportunity to use study leave as well. There are, I think you can use a couple of days per year for personal study, so that should be fine. Normally, obviously, the answer is to see real children. It's a bit tricky at the moment, but you are seeing real children all day, every day, and so just use every interaction you have to try and do things in as beautiful and systematic a way as possible. If you're seeing someone in A&E with croup, that doesn't mean that you can't do a neuro exam on them, as long as they're well enough, obviously. And then, yes, remember the video station. So think about all those emergencies and temporary signs and things like that they can show as part of that, rather than the sort of standard bread and butter of the rest of the stations, clinical stations that are the more chronic illness. Time yourself, stick to it, exam conditions for all of your practicing, otherwise there's no point. Even more so is the communication, is the presentation in terms of your talking, because if you can't interpret the signs and then talk about them, you can't prove how much you know. Organising revision sessions and mocks can be helpful. Don't forget about all of the other little bitty things like Snellen charts and musculoskeletal and thyroids that do come up. And also don't forget about the communications and history. I've got a thing at the end, but the pink communications book is lovely and you can do them all and then you will feel confident going in. Familiarise yourself with the equipment, particularly with the development station. We've got a picture of the stuff coming up. And all of the mark sheets for the exams are on the RCPCH website, and so use them with each other when you are revising. Before the exam, check you've got all your IT things. You'll get all of the details from the RCPCH, including the thing to check that it's working. And you've got to check that you've got the right capabilities. Make sure that all of the children and pets are locked away. You still need to have your ID and admission document to show the camera before you start. You can have water with you, but it has to be in a clear bottle, it says. And then in terms of the dressing, obviously it's slightly different in front of a camera, but you still need to be vaguely sensible. Generally, don't stress too much. You are being watched doing what you do every single day. Just do it and feel confident. If things don't seem to have gone wrong, if one of the stations just doesn't go right, move on. If it's often that it hasn't gone as badly as you think and you're worrying about it and it will affect the next one. Don't make up signs. It should be hopefully easier in terms of this, where they're providing the things that you're looking for as you're going along, but it can happen. And remember, sometimes the examiners get things wrong, and so if there are any issues, technical or otherwise, then raise them on the same day so that they can be taken into account, and then forget about everything until you get the results. Usually they take 6 weeks, but they've said that with the virtual form it might be quicker than that. If it doesn't work, if you fail, the world will not collapse. I failed the first time, and the second time lots of things changed, but in terms of trying to be more confident, making sure that I was really being strict with myself in revising, all of those things with timings and things like that are very important. Lots of people didn't pass first time. I know of at least one consultant who sat the exam 7 times, and they are fabulous, and it doesn't matter. Revising is the thing that makes you better and makes you better doctor. In terms of compared to the written exams, revising for the clinical is useful. You do learn useful things. Sometimes it is just luck. Sometimes you know what went wrong and just don't do that again. You get a copy of all your mark schemes, and there should be useful feedback for you to take on board. If you're borderline, consider a remark. They have, since the changes to the exam a year or 2 ago, it's more difficult to do that and more expensive to do that, and it is less likely to work because of how they are doing the marking, but it's always worth considering if you really are borderline. these are just some of the useful things. So the RCPCH website is obviously fabulous. The MRCPCH website from the London School of Paediatrics has lots of videos and things which obviously are for the face-to-face form of the exam, but are helpful regardless. YouTube, obviously, just go through videos of gates and things for your video station. Things like Open Osmosis and other sort of podcast type things are great. Think about how you're going to explain things to patients or parents in the setting. So think about guidelines, patient leaflets. GOSH has lots of layman term explanation type things for different diseases, which are good. NICE guidelines, SIGN guidelines, bioethics, Nuffield, Epicure, BAPM have all sorts of things about if you were to discuss things like resuscitation at the borders of viability, things like that. And these are some of the books and things that I used. So the communications one is definitely good in terms of giving you a whole range of topics and things to prepare from. The MRCPCH website. Some people like these Mary Sheridans for the development. Personally, I thought it was a bit more than you needed. We'll go through some other more useful things in the development section. Remember to look at the RCPCH progress curriculum, because that is effectively what it is testing. You need to be meeting that syllabus to pass. Pass test, this has lots of useful information and things. These books are the past paediatrics books are both quite old, so therefore a very different form of the exam, but they do have a lot of information and guides in terms of things to focus on. Outpatients is not the outpatients that it used to be, but looking at children in all of your clinical settings, both unwell and the well siblings, can definitely give you a lot of information and all of this. Where are we up to with things? What have we got in here? Oh, is anyone, can we mute anyone? Do you think the exam is going to be recorded? They haven't said that it will, but I suppose it could be in terms of any issues going back. Don't know. We can ask. There will be a webinar with the RCPCH in a few weeks' time, and I'm sure they can answer that more accurately. Were there any other questions, Josh, that I can't see?
No, that's grand. I'm sure it's possible for us to get the slides out, is it, KT?
Most definitely.
Yeah, we'll do that for all of you guys. It's a really good question about the recording, actually. I don't know, I had quite a good look through the RCPCH website today and couldn't find anything about that. I would imagine that they'll have to tell you quite explicitly if they're going to. Yeah. But yeah, if you guys have the opportunity to get along to the webinar and ask, or they've got emails for that you can drop some questions to on the RCPCH website as well. I'm sure they'll appreciate it if you don't bombard them with stuff that can be answered on the website, but if there is something you really want to know that you can't find the answer to, then do make use of that.
Yeah. In terms of writing things down, it's a tough one. I definitely found making notes helpful, but you have to think about, I suppose, all of the stations. What you're doing is a more rote learnt type examination, but trying to make it sound as fluid as possible, and you just have to practice is the answer. Do you have anything to say, Josh, on that?
No, I think just that they are very aware that it is an issue and it's a far from ideal scenario, and I think they will be taking that into consideration. Even under previous circumstances, they wouldn't be expecting anyone to recall very, very specific details, like if a number happened to be mentioned for whatever reason, that sort of detail is not going to be expected. Even before, and even more so now, I think they'll be more aware of that issue, and I'm sure they'll be treating people with kindness and consideration on it.
Because of course they have just listened to you take the history, for example, so they don't need you to recall everything.
Exactly.
any news about the number of seats in the UK. So what I had been told was that there were around 90 people sitting in this sitting in November, and then they were aiming for sort of in the hundreds for the next sitting to try and make up for the people that couldn't do the details of the webinar. They haven't announced it yet, so just keep an eye on that RCPCH website page, and they'll be going up there. If I hear in the next few days, I'll send it out when I send out the slides. Why are you not omitting the parts that candidate pass in the first trial, for example, from the second trial? Sorry, I don't know what you mean. Do you know what?
No, I'm not quite sure. Seems to suggest that parts are being carried over if they've been passed previously. But I wasn't aware of that.
No, don't know. Is there a guide to this technology to use? Yes, it's using Praktik OSCE, and there is a link on that page where you can go through, and there's some sort of not pediatric specific but some examples of people using the technology, and you can have a practice run once you have signed up for the exam before you start. Can it be done on a phone? They suggest not, ideally, just so that you can see the examiner, you can see the person the role player, and any information or signs that they're showing you. What do I mean by don't make up a sign? So like if you sometimes in the middle of the exam when you're getting flustered and you're trying to work out what's going on, you can look at a photo or look at a child and say, ah, yes, they have wide space nipples or whatever, and they don't, and you're just throwing up words. So it's just to be careful, and it's a thing I do is definitely verbal diarrhea, and so you just have to sort of pull it in. Clinical cases will be the same for UK trainees as the overseas one. They said that they're trying to make them, they're starting with the UK ones, and then once they start the overseas ones, they're trying to rewrite scenarios so that they're specific to the countries that they're doing them in. How well that will go is anyone's guess. Yes. Latest guidance, RE note taking is yes, they've definitely made a big statement saying that they're not allowed. Is the certificate accepted outside the UK? Do you mean? I don't know what you mean.
I guess the exam qualification, in which case it's treated just as all previous ones. So yes, if it's something that the particular country or organisation that you're working for recognised previously, then they still will do.
How are they addressing the fact we can't practice in the usual way, especially subspecialties? I mean, it is being taken into account in terms of the marking and things, and the examiners all seem very aware of the difficulties. They are facing those as well. I suppose partly you aren't going to be examining patients in the same way that you would be during the exam either, and so you can practice. You could have virtual practice with your peers while you're doing your revision, but no, it's obviously not ideal. Scenarios will be country specific or UK based only. So yes, they are planning to do a range overseas examples as well, and that will try to be country specific, but they said that you can apply to sit in a different country, obviously with timings, but they said that because everything's according to the standard priorities of getting a place on the exam, you won't necessarily get it if you're applying elsewhere. Extended clinical station, what changes expected? Don't worry, there's a whole talk on that in a minute. And how long will the new system continue? How long is a piece of string? COVID could last forever. They won't write in the certificate online MRCPCH. MRCPCH is MRCPCH. Could you mute yourself, please? Exam from host country or all from UK. So the UK exam will be UK examiners. Other exams will be their countries. Yes. Right. Shall we move on? Josh, are you ready?
Yeah, great. I'm sure, guys, you'll have loads of questions specifically about how everything online is going to work, and they're all good questions. Do pop them in the chat whenever the thought strikes you. We'll keep an eye on them, maybe jot them down, and maybe it's most sensible if we address a lot of those at the end, perhaps, because I'm sure there'll be loads of them. But we'll make sure we save some time at the end to answer things as well. But yeah, should we get stuck into the next one?
Are you able to share? And I'll
yeah, just doing.
يا بنتي سيبيني شويه.
Please mute yourself.
غريبه قوي، مش لسه قايل لك.
Okay, can you see that, Katie? Perfect. So I'm just going to have a chat about the history and communications stations, guys. This is one of the more straightforward ones in that it hasn't changed very much at all, really, now that it's going to be online, apart from the technological adjustments. But in terms of the structure and the content, it's pretty much the same as before. So aims of the history station are to be taking a focused, and focused should almost be underlined there, history, summarize that history, identify the key issues using your clinical judgment, prioritize and formulate a management plan. So quite a holistic approach to a care, a bit like seeing a patient in A&E, excluding the examination part, I suppose. The issue that you're addressing will either be something new in that patient, so a first presentation, something like epilepsy or a first seizure, headaches, joint pains, other examples given there. Or it may well be a specific problem in a child with an established diagnosis, so weight loss in a diabetic child, for example, or feeding problems in a child with cerebral palsy. And clearly there are multiple things that could be contributing to those presentations, and your job will be to explore those options and try and work out what's going on and how to proceed. So obviously there's no examination as such involved in this history station, and that includes any talking through, but you may be given some extra information in the form of numbers or any other data like growth charts or investigation results. And you'll most likely be given that at the beginning of the station, but I guess there's a chance that you could be presented with new information during the discussion with the examiner towards the end. So one thing RCPCH have done on the website that you guys have all got to go and have a look at is provide a breakdown of how the structures is going to work on all of the online format, which I think is really, really helpful to understand how it's going to work a bit more. So the one that they've given, and this is lifted straight from the website for the history station, is that you have 5 minutes before the station actually commences. And in that time, the idea is that you enter the station, which is the virtual station, of course. You have your candidate information sheet to read. You may have some other cues to be looking over as well, and that'll be made very obvious to you. After 4 of those 5 minutes, the invigilator just confirms that you've read that information sheet, and they will announce that the station has started at the end of the 5 minutes. And at that stage, obviously, the examiners will also enter the virtual station, introduce themselves, check your details, and just provide an introductory statement as well to make sure everything's clear. And it is a really good idea to have a look online, links through the RCPCH website as to how the format of the program is going to work, and you can see video examples of it, not for the MRCPCH exam, but for another unrelated mock exam, but it lets you explore the platform. And I think they're hoping to let you guys have some access to the platform, or at least they're exploring that option prior to the exam so that you can familiarize yourself with how it'll all work a bit more. So definitely have a look at that. That's helpful to know what to expect. And then on the history station now, you've got 14 minutes of the total 23 minutes of examination time, during which your task is to take a focused history from the role player. And I believe they almost will all be role players, or all of them in fact, and not actual patients on this time around. And then at 9 minutes, the invigilator is going to announce that you've got 5 minutes left. So you do get the same kind of warnings as you go through that you would expect. And then at the end of those 14 minutes, the invigilator will ask you to stop taking the history. After that, you move on to the latter half of the station, then the second part, which is 9 minutes, second part of the clinical, of the actual examination aspect. During that time, it will be about discussing what you've gained from the history and where you go. So talking about the patient's problems and then exploring a management plan with the examiner. You'll be guided through that, of course, so you just have to respond to the questions that are proposed to you. It will probably start with something along the lines of, can you briefly summarize the history that you've taken? And then they'll guide you through with questions as you go through those 9 minutes. Again, you'll get a warning when there are 3 minutes left. And then at the end of the 23 minutes, the invigilator will announce that the station is over. Hopefully that's all clear. You can see on this previous slide here that there are a few domains that are designed to be addressed by each of the sections, and that just refers to how they mark you as they go through, so it is worth being a little bit familiar with that. I wouldn't worry too much because it's nothing surprising, as you can see here, if you just have a look at the meet standard column, because that's where everyone wants to aim to be, of course. I'll leave you some time to have a little look through there, but it's nothing surprising, so it's definitely helpful to have a look at. But you certainly don't need to be memorizing this, and you don't really need to be having it at the front of your mind on the day of your exam. It's just helpful to have familiarized yourself with beforehand to make sure you know you're doing the right things when you're practicing. Okay, you will get the slides and it's all online as well, so I'll just move on. So what's expected in the history station? Obviously, and probably most importantly of all, being friendly, polite, professional, interested and supportive. I think really in the exam as a whole, the most important thing is just being a nice person, like I'm sure you'll all be as paediatricians. But really it does count for so much, just being nice, being as confident as you can, even if you don't feel like it on the day, which I'm sure we all don't. Those things go a really long way. So of course you want to be trying to relate to the role player in this scenario and try and go past all of the artificial nature of everything, which is going to be even more true now that everything's virtual. But really try and get past that as much as you can and connect with the role player as best you can. Like I said, the fact that the history is designed to be focused is very important. 14 minutes is a good stretch of time to get a decent history in, but you're not going to have time to go into every single thing that you might want to. So you do have to be focused on the current problem and really ask the questions that you think are the highest yield things. And then if you have some time at the end of those 14 minutes, you can always go back and ask things that you've forgotten or skipped over a bit before. Obviously, you want to be asking clear questions, open questions to start with, closed questions as you go, and no jargon. You structure your history in the usual way that you would do if you were seeing a child in A&E, for example, with past medical history, working through to family, social, etc. And what I would say is that there usually is a social aspect in most of the histories. So you definitely don't want to be leaving that as something till the end just to tick the box. There usually will be quite a significant social problem that's contributing to the child's presentation. So leave a good amount of time for that and give it due attention. That stuff, unsurprising, immunizations, drugs and allergies, previous treatments, current medicines, all things that aren't surprising. Do remember to explore the role player in this case's concerns, fears, expectations and feelings, and you can be asking them questions like that, and you should be really respond to questions that the examiner poses to you appropriately, of course. Do clarify, that goes for the exam as a whole. If you ever have any questions, whether it's something logistical with regards to the virtual platform or whatever the question is, you're absolutely within your rights to ask that at any time. And they'll be more than happy to respond, and it won't be frowned upon in any way. Clearly show empathy, willingness to help, verify and summarize the history, and investigate and treat appropriately. So that's just referring to the management plan aspect of things that will be covered at the end. So you'll see there, I guess, that a lot of the points are not so much about clinical knowledge and much more about communication, which I think is a fair representation of how you'll be marked as well. Some practical tips, if you're asked to summarize, which I would guess you probably will be at the start of those 9 minutes, don't just repeat the whole history again. Like Katie said, they've just heard it. You don't want to bore them. They won't like that. So be very succinct. And I think all of us have a tendency to say too much rather than too little. So really do practice being as succinct as you can. You're going to have got quite a lot of information in those 14 minutes, and you have to be condensing it down to a summary that's probably less than 30 seconds long. People do it in different ways. Some like to use SBAR, some like to use a problem list like a clinic letter. Doesn't matter how you do it, just try a few things out and go with whatever you're comfortable with. We've said about being having a focused history, and yeah, you can try to anticipate some of the examiner's questions. So you get a good stretch of time at the beginning, don't you? You get 5 minutes at the beginning to be familiarizing yourself with the history, yes, but you will have some time spare to start thinking about what questions you need to be asking. And you can also, even at that stage, start thinking about what questions the examiner is likely to be posing to you. So just use that time at the beginning as best you can. We've got a couple of examples now we can have a quick work through. All of the examples today are lifted from MRCPCH website as well. They are from pre-virtual times, but I don't think the content will have changed that much, to be honest. So I think they're all completely relevant. So in this example, you're a specialist registrar in the Children's Rapid Referral Clinic at a district general hospital. You're talking to a 6-year-old boy, Gregory, and his mother, and the task is to take a focused history, aiming to explore the problem indicated as you would in the clinical situation. You may answer questions, and after the consultation, the examiner will focus on your management planning. So you haven't been given very much information there at all, have you? I think in reality, you'll likely be given more information, and often it's in the way of a kind of GP referral letter or that sort of thing. But it is possible that they give you something very, very generic like this, and you have to think a little bit more on your feet. But this is probably more unusual. I'd expect them to give you more information on average. So, oh, I'm sorry, here we go. This is that information. Perfect. So this is the GP letter. This boy who was born prematurely and has been seen regularly at your outpatient clinic, mainly because of respiratory problems, has been noted by his mother to have become tired and listless over the past 3 months. On examination, I can find no significant abnormalities. I should be very grateful if you would see him and advise on appropriate investigations and management. Got a bit of background information that he's seen regularly at the outpatient clinic. He required assisted ventilation for a long period as a neonate. And you've got a bit of data there in the form of some anthropometry, and he's got a low weight and he's short. It's going to be a bit tricky to do this in the usual interactive way that we would, of course, but I guess just spend a little bit of time having a think about what questions you might want to be asking, what information you really need to be getting from the history, how you want to balance your history, where your focus needs to be in a case like this. And then you can start anticipating some of the examiner's questions as well. So I'll not painfully make everyone do that now, but it is worth going through these examples because they are official ones from the RCPCH, and just having a think about them yourselves, and you could use them to practice with your colleagues, for example. And then the second example we can just whip through quickly. Tara's a 15-year-old. She's got diabetes, type 1, was under the local hospital. They've moved to the city and her care's been transferred to you. It's her first visit, and your consultants ask you to take a history so that you can be a bit prepared. She's got some data there as well, and your task is to take a focused history and then discuss the patient's problems, possible diagnoses in rank order, and your management plan. So there we go, a couple of examples of the histories. And now we'll just move on to a quick run through the communication stations as well, which again are not very much changed at all from the pre-virtual era. So if anyone has had a go at the exam before, or at least familiarized themselves with it before, then it's very, very similar. So the aims of the communication stations: clearly communicating appropriately, factually correct information, so don't make stuff up, in an effective way within the emotional context of the clinical setting. It will always be a role player who you're interacting with in the virtual format, but they could be acting as various types of person. They may be a parent, they may be a child or an adolescent, they may be a health professional, a member of the public, they could be a student, that's quite a popular one these days, or a junior colleague who you need to do a little bit of teaching for. I guess this thing about a telephone conversation is perhaps a little bit less relevant now because it's going to be a little bit that way anyway. And during the communication stations, the examiner will just observe. They won't be asking you any questions. However, if you have a question that you want to clarify with the examiner, then please do so and they will respond. That's absolutely fine. If you want to clarify the task, or if you're having some issue, then don't just think that you can only talk to the role player. So here's that same table again, but for the communication station. So these first 5 minutes are essentially identical, and they will be for the vast majority of the stations. So here you'll have a good amount of time because the spiel you'll have will be quite brief. So you'll have a lot of time to think about how you want to attack this communication situation, what you think is likely to happen, and how you're going to handle those situations. And then you have the 9 minutes in the communication station where you're undertaking the discussion with the role player. Again, you will be warned when there are 3 minutes left. And at the end of those 9 minutes, you'll be told that the station is over and asked to move on. So a much more simple structure for the communication station, just the 5 minutes before and then the 9 minutes of a communication scenario during. And again, you can see here how it relates to the generic mark scheme across the clinical domains that are deemed to be relevant in the communication stations. I'll whip through that quickly now. You can have a look through in your own time. A few different types of scenarios that could come up in the communication station. The first is information giving. That would be quite a common one. So for example, please tell this teenager about their diagnosis. Another might be breaking bad news, explaining the results of a scan and the implications of that. Could be a consent situation where you're asked, for example, to explain why there is a need to do a particular procedure. It might be a critical incident. That would be another fairly common one where you're asked to talk to the parent of a child who's been given the wrong drug, as an example. Ethical situations are quite commonly tested on. And the example here is discussing the problem that Anna's refused to have any blood tests. And education scenarios, like I say, becoming more and more common. So, for example, explaining to the SHO that she can deal with this situation. Just a few examples there, could be lots of things. There are really good resources for the communication situations to give you things to practice with your friends and colleagues that Katie mentioned before. That pink communication book's really good, and the past test book's got quite a few in as well. But you can just mix them up as well. They're all very reasonable, and at least the vague idea of them is relatively predictable. What's expected? Good communication in summary. Appropriate introduction, structured conversation, rapport and body language. That's quite a good one, I think, to hone in on because it's going to be difficult, isn't it? And that will be factored in for sure. But I guess the reason I mention it is that I would suggest, if it's possible, to keep your arms free and your hands free when you're doing this. That might be quite helpful. For example, if you're there holding your phone, that's probably going to be quite tricky to develop as much of a rapport and use the body language in the same way as you would if you had your laptop set up a meter or two away from you, for example. So have a little think about that kind of thing. It's a dialogue, non-monologue, listening skills, empathy and sensitivity. These are all things that will be expected, and they're all pretty obvious, I think. Again, not using language, using clear language and no jargon. Use of diagrams is not going to be feasible, of course, anymore. But I guess you could always mention it. It's going to be a bit difficult to draw in without. So I would probably do something more like referring to an imaginary resource, like a leaflet or something that you could give to the actor to make it helpful for them. Clearly, you're going to have to tailor the way you interact depending on who the person is. If they're a colleague, then you're going to need to be a little bit more professional. If they're an adolescent, then you might, again, need to tailor your communication style accordingly. You do want to make sure that you focus on the task that's set, and then always check understanding and invite questions and all the usual sort of stuff as you go. Some top tips is not a test of the sheer amount of information you can communicate. That's really important, I think, and actually often, at least in my experience and those that from others that I've spoken to, there won't always be that much to get across in the communication stations, and you have quite a lot of time, quite rightly, to really just focus on how you're conveying that information and how you're interacting with the role player. So don't expect there to be loads and loads of information that you have to get across or that you have to get out of the person and that sort of thing. It should be quite a simple task, and it's much more about how you communicate, of course. Once you hear the warning with 3 minutes remaining, that's when you want to think about summarising, checking understanding. It's worth checking understanding at quite an early stage, certainly not leaving it till the last minute, because if you have missed anything, then usually the role players will be quite nice to you and they'll ask anything and guide you to something that you may have missed if you have done. So that could be something that needs a little bit of time for you to address well. So you can always check understanding once when there's, say, 3 minutes to go, and then if they don't have anything, take that as a good sign, carry on having a conversation, and you can always check it again if you needed to. Or if you're comfortable and you finish the station early, then you just stop. That's absolutely fine. Yeah, so we mentioned that you might want to signpost to other resources, next steps, next meetings, an appointment. So I guess it's all just trying to put yourself in a real life situation when these things would be taken for granted. Try to select the most appropriate information, provide information that is correct. So I guess what that's getting at is don't feel obliged to be providing lots of clinical detail that you're not completely confident with. These scenarios shouldn't be very complicated, and you will definitely not be expected to have any more clinical knowledge than the standard, which is of a newly qualified ST4. So if you're not completely sure on something, then the right thing to do is to say that you're not completely sure and say how you would rectify that in this situation, whether it's that you need to have a chat with your boss or whether it's that you need to refer to a specialist, whatever it may be. But don't feel pressured to provide information at a level that you're not comfortable with, because that will not be expected. And I think we've covered those last two. Got some suggestions on interpersonal skills there. All of this stuff, again, is going to be extra challenging over the virtual environment, but I think give it a good go. Be comfortable where you are, and just do what you can really to show as much empathy and interaction as you can. I think I'll not spend much time going through the examples because it doesn't work so well, does it? But you can find these on the slides that we'll send around, or on the RCPCH website as well. And so do have a look through them and practice them with your friends, but they're all pretty reasonable things. Any questions, just pop them in the chat, guys.
The only question I could see so far was just about how focused is the focused history.
Yeah, so a good question. It's gonna depend, isn't it? The only thing that's written in stone is that you have 14 minutes. And that's really what you have to play for, and then it's up to you how you use those 14 minutes. And it's going to depend on the particular scenario. Some will be very, very specific. There might be one or probably two very, very specific issues that come up quite quickly and you need to address those in more detail, or it might be a much broader scenario with lots of different things. So I think the answer is you just have to be guided and you just use those 14 minutes the way that you see most appropriate. And you respond to cues that you're being given. Probably the role player will be, if it looks like you're lagging behind and you're going a bit slow, most likely they'll be giving you some cues that you need to speed up a little bit, and vice versa too. How are we going to explain by a drawing? Yeah, I'm sorry, I should have removed that from the slides. You're not going to be able to, but you could refer to another resource like a leaflet or something like that, where you could say that there's a good diagram just to illustrate to the examiners that you're struggling to articulate this complex concept in words, and it would be helpful to try and use other communication methods to assist in that. But I hope that they're factoring that sort of consideration in when they're designing the tasks this time around, and I'm sure they will be. Can I discuss with the role player as if I discuss through a diagram? Hopefully I've already answered that. Can you follow me through the diagram to make myself clear? Okay, I hope I've already answered that, Hiba. If I'm missing your point a little bit, then let us know. Anything to add, Katie, about anything?
Nope, no.
Grand. So Reaper's just asking, how will I be sure I've asked a focused history without a checklist? You won't be, Reaper, I suppose, But I guess it's really just trying to replicate real life a little bit, isn't it? If you're in your clinic and someone comes in, you don't necessarily have a checklist because every patient is a little bit different and the situation is going to be different. So you do need to work through the standard structure of a history presenting complaint, past medical history, etc., through to social history. You do need to have that framework, but that's about where it ends. And you don't have to go through things in that order, of course, just as you would do in real life. So you have to be flexible, I think, and responsive to the situation.
Okay, and then the next presentation up. Okay. Gosh, I think you need the clinical stations. So the aim is, as always, to assess that the standard of a newly appointed ST4 and to assess that a candidate can undertake a structured and systematic clinical examination and then identify those clinical features and go forward. So now there will be the two types of station, the extended clinical and the short clinical. So the extended clinical is a big old 23 minutes. It's a lot on one slide, but I thought I'd just make it clear. So the same 5 minutes at the beginning in terms of entering the station, reading through. I'll go through what the different types of cues are afterwards, and then the examiner then joins and gives the introductory statement. The extended clinical station is almost a combination of a history station, as you've just heard about, plus the sort of short clinical station, and then going through the management plan as well. So it's basically the most real life like scenario type station. So a breeze. So the first 10 minutes are then generally a focused history in which you would then have a role player to speak to. You'll have timings through that, and then you stop taking a history, you summarize your key findings, and then start going into your examination based on your history and what the examiner is telling you. Once you go through your examination, you go through it step by step, and the examiner then provides you with clinical signs as you elicit them. You then provide your interpretation of those signs. So if there is a rash, what does the rash mean? Then you have a discussion about what you found in the history and the examination, in terms of what you would then write in your consultation letter, what would you say your diagnoses are most likely to be, and what outcomes that would imply. And then discussing about your management options, so what tests and treatments and things would you consider depending what the scenario is, what follow-up would be required, and then any advice and planning in terms of for the parents going forward, plus of course your warnings all the way along. So it's a lot to pack in, but you've got a long time to do it, and they will tailor the situation for what that is. The short clinical station is the one that's more similar to the ones that you know already. So the 5 minutes, as always, in terms of preparing yourself, 6 minutes with the examination, and then 3 minutes of discussion. So the 6 minutes, you have to provide your step-by-step process of the examination with the cues as you go along, plus then a summary of what you found and what that means. Then going into your differential diagnoses and how you would investigate and manage. So these are the criteria then for the different stations. So for the extended clinical station, again, all of these will be emailed out and are on the website, but going through the different domains covering all of the areas that I'm sure you can guess: be sensible, safe, etc. And the short clinical, so obviously because you're not doing the history taking, there's fewer domains that are covered. So in terms of the stations more generally, in theory, any kind of system or case can come up. There will be no patients at all. It will all be videos, images, audios and descriptions. There will be role players in the extended clinical station for the history taking part, and they can be as before parents or teenagers or similar. You need to talk through your examination and then be given the findings. So these are the different types of cues that you can be given. So you have to describe your examination. This is the thing that you really need to practice. So as opposed to previously you'd be going around the ward examining hundreds of children, you need to be describing how you would examine hundreds of children, maybe over video to practice as well. You need to be structured, systematic in your examination, the same as you would be, but it is important to practice because, for example, I was thinking about it earlier, trying to explain how you do a development examination, for example, without it sounding just like a list is tricky. And so you have to sound like you know what you're doing and not just that you've memorized a list. And do always think about what you're looking for. So rather than just saying, I'd examine, I'd look at his chest, you would say, I would look at the muscle bulk and compare both sides. I'm looking for any wasting, any fasciculations, all of those sorts of things. Then you've got the two different types of cues. So there are dependent cues and universal cues. The dependent cues are the ones that you will get as you go along. So as you're speaking to the examiner, they will then give you a result, but you have to have said the item that you're examining before you're then given it. So I would test the lower limb reflexes with a tent and hammer, and then they interrupt and say the reflexes are brisk on the left. And so they haven't confirmed exactly in terms of, because they're still piloting, about how they're going to interrupt, but they're planning for something like the examiner raises their hand and then tells you the finding. But when you're practicing, remember to practice like taking a break once you've said something, just in case they want to give you a finding so that it doesn't throw you off. Those are the dependent cues. Then you've got the universal cues. So those are the ones that come at the start of the station. And they're things that if you walk in the room and you can see that the child is in a wheelchair or they've got a big scar down the front of their chest that you wouldn't possibly miss, they will be showing you then. So they are photos, videos, things like that. So those are all part and parcel of those first 5 minutes. They'll be available for you to look at. And so from that, you'll actually be able to start thinking about, you'll have an idea of what's coming next and you can prepare yourself. Purely because there are, because of technical issues, actually some of the dependent cues you will be given at the beginning too. So any of the dependent cues that in theory you wouldn't find out till later, you might get 2 in that 5 minutes. So this is a bonus for you, make the most of it. So they were saying that they gave an example of a murmur. So if they need an audio of what the murmur sounds like, that will be with the cues that you get at the beginning, even though in theory you wouldn't hear it until a few minutes later when you examine the chest. So silver lining to the virtual form of the exam, perhaps. So this is this is the list from the guideline that on the page is on the MRCPCH website, which isn't incredibly helpful in that it basically is all of the things, but it's just an idea in terms of making sure that you're not missing anything. So, for example, growth and nutrition, you wouldn't automatically always think about preparing as an examination, but it can come up. You can have an assessment of someone's growth. In terms of the things to think about, this is just a sort of gathering of things that might come up for you to think about, but obviously there is no end to the list. So in terms of your abdomen, think about the different signs like hepatomegaly, splenomegaly, clubbing, PEGs, jaundice. All of these things can be shown in photos or videos, and so you could have come up. Urology, weight, hemiplegia, head sizes and shapes, cranial nerves, these things. And then cardiovascular, so you've got cyanotic and acyanotic. Would someone be able to mute, please? Thank you. So cardiovascular, you've got your cyanotic and acyanotic children. Actually, because it is a virtual exam, it might be that there is a broader range of the type of children that they could include. So it wouldn't necessarily be the most stable children that we would normally have. Remember to think about different scars, and don't forget about the blood pressure and the femorals. It's easy enough to forget them when you're in front of a real child, but in front of the camera, it's even harder. Musculoskeletal, so your spinal deformities, hypermobility, all of your different assessments for those things. PGALS is a useful screening tool, but you don't need to do it for every musculoskeletal assessment, but do think about it and do practice it. Respiratory, so it's all of those common things, or at least common in exam things. So cystic fibrosis. Asthma isn't always the most used in terms of these children don't always have signs, but bad asthma patients who have longer term sort of chronic changes to their chest might be included. And don't forget to look at in the mouth and at the neck as part of your respiratory assessment. So what is expected from you? It's all of these things that you already do and have been doing for years. You want an organised approach following a clear and systematic pattern. You just need to look and sound like you've done it before. And so the way to do that is to do it. And so practice talking through all of these things. You should be competent at assessing the areas and identifying signs, discussing the findings and about the interpretation and management. You should demonstrate your skills and knowledge to the level to progress to level 2 training. In terms of your sort of presentation tips, you have to practice. So once you've done your chatting through examination, you still need to do your presentation of your findings and what you're going to do. Get yourself a structure. It doesn't matter what, but get it and stick to it and make sure you can do it without any ums and ahs along the way. Think about your main findings, positive and negative, and then think about your differentials. You can already start thinking about what the kind of questions will be. You know there'll be something about the management or follow-up or something like that. You can be ready. This document is on the RCPCH website, and it's been adapted for the clinical exam, and it goes through every single station and how to do the examination. So this is your Bible when you go round practicing. Okay, any questions? Oh, hiya. There's lots.
I think we've addressed most questions. Yeah. Katie, Rani is just asking about notes again. So just to reiterate, it's not allowed to write notes at any time during the exam, unfortunately. The reason for that is that they're worried about people taking the content of the stations and showing them to other people. So they can't tell you to just leave all of your pieces of paper behind like they could in a real exam centre. Yeah. So that's annoying, and they're aware that that's annoying, but unfortunately that's the way it has to be.
Yes. Oh yes, you've already been on the case. Sarah Hallett, you missed the slide. So on the website of the RCPCH, they have an explanation of how to do all of the assessments. Let me see if I can go back to the slide. This is your Bible, and it goes through what they feel is the perfect examination for all of the different cases. Yes, you have to. You do have to tell the examiner all of the bits of the body that you are examining. How to describe an examination? I suppose. So, for example, you'd go in and You'd say, so I'm going to start my assessment by having a look at the hands. I'm looking at the nails for any sign of clubbing. I'm looking at the palms for any palmar erythema. I'm looking up the arm for any signs of scarring. I'm feeling the pulse, that sort of thing. Josh, have you got any other suggestion about an example of how to describe an exam?
I'm going to just pop a link to what RCPCH have to say as a very specific answer to that question very usefully.
Beautiful.
So that's a helpful thing to have a look at for sure. We really can't reiterate enough how much information there is that's really, really useful on the RCPCH website. I think they've actually handled all of this in a really commendable way, to be honest. It's a very suboptimal situation for everyone, and I think they're really doing their best to work with it.
Will we share the slides? Most definitely, and the video is being recorded and going on the LSP YouTube website. For the reflexes, how can you describe it? So just the same. So I will be checking I would like to check the lower limb reflexes using a tendon hammer, or I would shine a light into their pupils to check their pupillary reflex.
And I think, just remember, guys, if you ever describe something in not enough detail, then they'll probe it with you, and that's fine. So they'll say, oh, but how exactly would you do that? Can you tell me a little bit more about that? Or can you, it's a bit of a rubbish example maybe, but can you tell me the landmark for where you would listen to the heart in this case, or something like that? So if you don't provide enough information, they'll give you cues, and they will give you cues. Be ready for that. It doesn't mean you're doing badly. It's a normal thing.
Most definitely, and they are all lovely people. They're pediatric consultants. How could they not be lovely? And they are wanting you to pass. So don't worry too much. How do you remember a whole history without paper? You do it every day. That is your job. You know how to take a history. Yes, it probably is quite a lot of time saying things and then listening to the answers, but they are taking this into account, and that's part of why they're doing these. They're doing another pilot in a couple of weeks' time to make sure that all of those things are working, and they have gone through and looked at the mark schemes for all of these things to make sure that it is allowing that time. How can your time be managed? By practicing, really.
Yeah, I think all you can do, Glam, is practicing. Make sure you're practicing to time strictly. And then if you've got, obviously, where you have to spend more time varies in real life, and they will give you cues for that as well. So if they think you're spending too long at the beginning, then they will rush you through things a little bit more so that you get to the important things. And again, I would expect that to be a part of the normal process. Don't take that badly.
They can bring critical cases. In theory, yes. So they, because you're not having to bring children into the real thing, you could have a slightly more unwell child that wouldn't be suitable for a face-to-face examination using those, the photos, videos, and what have you. But typically those kinds of children are covered by the video station. So who knows? I would imagine probably not, but. What computer character qualifications needed? So there is a beautiful list on the website of what types of things you need for on your computer to be able to do the exam.
I think there's actually a way you can try it on. You can go to the website on the device that you're going to use, your laptop or whatever, and it will just tell you that your device is adequate or not. I'll try and get the link again now. Beautiful.
Are we allowed to keep the list of equipment available for the development station? We are going to do the development station in just a minute, and they have included on the website a photo and list of the equipment that you're allowed, and it will be shown as part of those universal cues at the beginning of the station. Heart murmur audible or verbally explained? I suppose it could be either, but it is one of the things in their examples that they've said would be an audio, could be an audio. Someone's got their hand up. Do you want to say out loud, or do you want to just put it in the chat? Don't know. Go ahead, Josh, on to the next.
Perfect. So next we've got the development station. Again, this is one of the ones that has changed a little bit, of course, because it was previously reliant on having children and a parent usually, and that's not going to be the case anymore. There are some upsides to this virtual situation, I suppose. Always good to take the upsides where they come. One of those is definitely that you won't have to deal with kids not doing what you want them to do, which is a big anxiety actually for a lot of people, in all seriousness, previously. So that is a good thing to know that is not going to be an issue. And I think it's particularly true for the development station because you're potentially asking small kids who may or may not be significantly delayed in the domain that you're assessing to do relatively complex things. They can get distracted, they've got behavioural issues as well or whatever. So it can be a real challenge, and that's one challenge that's gone. So that's good. So the development station, the aim is to examine the candidate's ability to assess key areas of development, take a focused history again to explore reasons for these findings, including the impact on the child and family. So we'll go through it, but you essentially have a bit at the beginning where you're taking a history, and then the second part is the examination part or a developmental assessment. So you have some time to gather information, you then do your clinical assessment. You do have some equipment and toys. I'll show you a photo of everything that you have. Obviously you don't actually have, but these are the things that you are within your rights to be mentioning. And then you have a discussion with the examiner in the end about your findings and your management plan as well. As ever, you're aiming for a standard of a newly appointed ST4. That's, I think, crucial to re-emphasize on the development station. You are not expected to be a neurodisability community pediatric consultant. You're expected to be a newly appointed ST4 who may or may not have had a 6-month community placement, for example. And don't feel bad and feel like it's unachievable at all if you haven't done a community job. It's definitely not required. The assessment that you're doing is basic and it's a general peds type thing. You do need to put some work in because if you're anything like me, you didn't have much experience at all when it comes to this stuff, but it's completely attainable with the right preparation. And then that's another point on the right there that's very important. The children will have a developmental age of less than 5 years or up to 5 years. So they might be older than that chronologically. So it could be a 7-year-old, for example, but their developmental age will not be more than 5 years. So you only need to know your milestones up to 5 years is the point. So here's how the timing works again. As ever, you have those 5 minutes that are essentially the same for every station. You get your instructions there and some time to think. And then you have the first 12 minutes, which are the history aspect of it. So you'll be asked to take a focused history. We'll go through that in a little bit more detail in a sec. At 6 minutes, you'll have an announcement that you have a 4-minute warning left to finish your information gathering. And then at 10 minutes, you'll be asked to stop taking the history. And then you will be asked to briefly summarize the key findings from the history, which appears to come before you actually move on to your physical assessment, which in a way I guess is nice because you can sort of put that behind you. It's not like you then need to retain all of that information, especially when you're not allowed to write things down. So you have that little discussion, or at least summarizing what you found to the examiner, and then you move on. And then you have this 8 minutes developmental assessment or examination type step. So you'll be given much in the same way as for the clinical examination stations. You'll be describing a step-by-step process of what you would do using the equipment that we'll come to in a second in order to undertake the developmental assessment. As previously, you'll be given dependent cues, so the examiner will be interacting and reacting to you to try and get the best score out of you that they possibly can during your description process. And then you'll be asked to, as part of that, summarize the developmental signs that you've elicited and asked for an interpretation of the signs and what they mean. You then have a brief 3 minutes at the end to complete the total 23 minutes. So 12 for history and discussion, 8 for examination, and 3 for management type discussion at the end. So you'll be warned that there's just 3 minutes left. You'll be asked questions relating to the D1 domain, which we'll come to in a second, but essentially it's about forming a differential diagnosis. And you'll be asked about management planning. So for example, what follow-up and when you might want to be arranging, and if you need to involve other specialists and what other members of the multidisciplinary team would be of benefits to the child. And then you get told the station's done and on you go. So again, you can see the mark scheme. This is available for all of the stations. It's all very generic, not surprising stuff as ever that you can have a look through. Just focus on the meets standard column. That's all you need. But you can have a look through that in your own time. What's expected? You want to be gathering the key information with the history taking. So again, it does need to be focused. There'll likely be a specific area of the child's development that you're asked to focus on. So you'll probably not be, or almost certainly won't be asked to just assess the child's development and leave it there. You'll be expected to just focus on 1 or 2 domains, most likely. So they might say fine motor and gross motor, or whatever. Any 2 domains, for example, would be a common combination, but it could just be 1. Very, very rarely, I think it will be all 4 if there's a child who's quite physically disabled usually, and then it will be very, very limited what you can actually get out of the assessment of each domain, so it ends up being much quicker. And that's the sort of scenario that you may be asked to do all 4, but I think that's much more unusual. Here we've got a ballpark of how accurate you need to be with your assessment. So for a child of developmental age up to 2 years, RCPCH suggests that you need to be within about 3 months with your guessing. So I guess this is to provide you of how an idea of how detailed the milestones that you're learning need to be. So it's not too detailed. Blocks of 3 months is very reasonable. And then even when they're between 2 and 5 years, then RCPCH would consider blocks of up to 6 months being very, very reasonable for discriminating developmental ages. Regarding syndromes, the child may or may not have a syndrome or neurological abnormality. Your job is not to assess those things in any great detail. Your job is to assess the development only. Having said that, if there are things that are obvious, then you can mention them briefly. If there are things that come out in the history or whatever. But for example, if it comes up in the history that the child has Down syndrome, what you don't want to do is spend lots of time in your examination listing the features of Down syndrome that you'll be looking for, as in the non-developmental cognitive features, the physical features. That's not going to get you any marks. That's just going to waste time and not make the examiners very happy, probably. I'm sure they'll interrupt you and tell you if you start doing that, but all the better if you can remember not to do it and just focus on the development. And then, like I say, the last few minutes are to focus on management planning. So these are the items that you have available to you in theory. So these are the kind of things that you can be suggesting that you would use. So this is another improvement, I think, because I know when I did mine, I went in the room and there was just stuff everywhere. I've never seen anything like it. And it was pretty overwhelming because you kind of feel pressured to use loads of it, and some of it you've never even seen before and you don't know what it's for. So this is a little bit more manageable, but the same things still apply. You do not need to be offering to use all of these things at all. They are just tools in your armory to use if you want to. But I would suggest personally, you do whatever works for you, but I would suggest personally the most useful things are definitely the blocks and the crayons and paper for your fine motor, scissors and paper maybe. The books usually pretty helpful if you've got to do anything with language and communication. The kind of cups and saucers and things might be useful for naming, and the same with the doll and pointing out body parts. But you definitely don't need to be using all of it. Just have a think about it, know that those things are available to you to suggest, and have an idea of how you might use them. So focusing on the history aspect of things, what will your aims be? You can approach it in the usual way. Probably most of you don't have very much experience in taking lots of developmental histories if you're anything like me, but you can approach it in the usual way, as in a structured history presenting complete past medical history type structure, but you just clearly focus on the things that are most relevant. So you do, in all of that, want to be teasing out the likely etiology if there is one. So spend a good bit of time on the birth history, for example. Ask them about past medical history and any sentient events that might have happened. Family history, of course. You're going to be asking most of your questions in the kind of history of presenting complaint, the way that I would look at it, on targeted towards the domains that you've been asked to assess, whether it's fine motor and vision or whatever. But you do want to be very briefly at least exploring whether there are delays in any other domains, and particularly I would ask whether there are any concerns with vision and hearing. I think that's an important one, and in practice would significantly affect how you interact with the child, of course. Associated comorbidities, we've sort of said, I guess. Impact on the family is definitely important. Again, you don't have a huge amount of time, but do make sure that you are addressing that. And with that, I suppose, other social things like, do they have an educational healthcare plan, and which school do they go to, and this sort of thing. And yeah, members of the MDT that they're already involved for. So all very appropriate stuff. I think it's all very reasonable. Practice. There are children everywhere. They're not so useful for you now, I suppose, but still do practice with your mates for sure. Run through some different scenarios. Try doing it virtually. Definitely do it to time. Look around, a little bit less relevant, but you could still say that you would have a look around, just assess the patient from the end of the bed type thing. One sentence to say something like that is probably reasonable. Yeah, so this is how to structure the approach to the developmental assessment. Start with the easy stuff and then move to harder ones until you find the child's limit. And that doesn't mean that you have to start with the easiest though, so you don't have to ask a child who clearly looks quite old and looks like their developmental age is reasonably good to draw a squiggle with a crayon. You can start at something reasonable, but just aim low to start with, and then you work up to harder ones. This last one is just a little bit about how you phrase what you're saying in your discussions with the examiner. Just be careful about saying they can't do something and say something like, today they were not able to do this. Just to be a bit more politically correct. This is super helpful. You can see down at the bottom here, if you can see my mouse, where you can find it, but it's on the MRCPCH Pediatrics website. There's lots of good stuff on there. There is videos about developmental assessments as well, which is quite useful. Obviously, it's all going to be very differently structured now, so treat those with the appropriate caution. But they are useful to see some examples. But definitely this resource is super helpful. This is basically all you need to know for the developmental station in one page. Print this off on an A4 page, stick it on your mirror to have a look at when you're brushing your teeth or something, whatever works. But this is really helpful. I won't spend time going through it now, but just know where to find it, and essentially that this is the level of detail that you need to have. You don't need to have anything more than this. We've got some examples. I'll whip through them quickly. Again, you can have a bit more of a think about them in your own time, but I'll just grossly go through a very brief summary for each one, I suppose, so you can get an idea. I particularly want to point out some of the latter ones. This one's a more straightforward expected one, a 4-year-old with a right-sided hemiplegia. And then your task, as you know, will be to gather the relevant information, take the history, do your assessment, and have a discussion with the examiner at the end. You've got the examples of tools. You already know what tools and equipment they suggest that you talk about. So don't worry about this, what might be expected for the purposes of now. These are just to kind of illustrate some of the developmental milestones and how you might tackle them. If you do look through these examples in your own time, they've got long, potentially quite intimidating lists like this. Don't worry about that, because you don't need to be doing and mentioning all of this stuff. You just need to do whatever you have in your own mind to make an adequate assessment. So you don't need to be hitting every single thing. Some people will do some things and other people will do other things, and that's absolutely fine. You're almost certainly going to come to the same conclusions. These are just suggestions. So another example might be a 3-year-old girl with Down syndrome, and they ask you to assess her speech and language. So you see that they're asking you to focus on a relatively narrow domain rather than the whole development. And then here are some more tricky ones to have at least a little bit of a think about. I think these last few examples are quite mean, and I hope that they wouldn't come up, but clearly they have done in the past, and RCPCH think that they're fair game because these are all examples taken from their website. So do have a little bit of a think about how you might tackle these. So this is a 4-year-old child who has autism, and they've asked you to essentially do a brief autism assessment. So that's something that's a little bit different. It might require you to kind of have a different structure to what you might use for other examples. So just be aware, I guess, that this sort of thing can come up that's a bit more specific, and have at least a few ideas of how to tackle it. You don't need to completely change your structure. You still use the same basic structure, but you're going to have to tailor it in a different way for sure. That's a more reasonable one, an 18-month-old. They've told you already that they're a bit delayed and just asked you to assess the fine motor skills to work out how delayed. This is a 4-year-old and they've asked you to assess the gross motor skills. They've told you that they've got cerebral palsy. They haven't given you the GMFCS there, but I'm sure they will do. And then we've got a couple more controversial examples. This one's a tricky one. A 3-year-old with some loss of visual acuity, and they've asked you to assess the child's functional vision. I think this is a really, really mean one. So I sincerely hope that this doesn't come up for everyone. I don't even really know what functional vision is, or if that's a concept that's very well defined. So I don't think it's the best question ever myself. I think it's definitely very, very mean, but it is one of the ones that's from the RCPCH website. So again, just be aware that this sort of thing can, in theory, come up, and I guess spend a small amount of time having a think about how you would tackle it.